So let's start the webinar now. Thank you very much for attending, everybody. My name is Brendan McCauley, and I'm here from Future Technologies Incorporated, and we're pleased to have you join us. This is a demonstration of our product for healthcare solutions, which is FTI Catalyst. Hopefully this is as interactive as possible, so if you have a question or you want to raise your hand per se, please go right ahead and jump in anytime you have a question you want to ask. Today's demo primarily focuses on the challenges that are facing hospitals everywhere and how FTI Catalyst can help. Today's healthcare delivery system is, of course, under the gun to perform. It needs to perform quickly, agilely, and in a way that allows all people within the enterprise to contribute to the bottom line in many ways. Whether you're an ACO or you're a nonprofit community hospital. So we are focused on these new people that will be hitting the streets essentially with Obamacare and the Accountable Care Act. This means a lot of new business for you, and it also means a lot of new costs and a lot of new services and patients in your lobbies, EDs, and ORs as they become patients in your facilities. So I know that for today, if we could just fast forward to what might lie at the end of the rainbow for you in the big picture, what we're hoping for is a state of awareness, accountability, and an understanding throughout service lines, as well as even nurse units, nurse managers, and of course C-suites, awareness, accountability.
Kathy has joined the conference.
Oops, we've got somebody jumping in. Hi, Kathy. Welcome. My name's Brendan McCauley with FTI Catalyst, and we're just getting started, and you haven't missed a thing.
Great. So, wonderful.
Welcome. Thank you. We're focused today, as I was just saying, on creating awareness, accountability, and a sense of urgency for profitability within your organization, and awareness of service line managers, by finance staff, of the daily drivers of profitability, so we have levels of accountability to performance and productivity metrics. So today what you're going to see is a balanced scorecard approach that comes ready to go as a plug-and-play and source-agnostic system. You may have interest in labor cost overruns. You may have interest in looking at direct variable costs and their effect on overall case margins and profit margins. Perhaps you want to look at productivity such as nurse ratios. Perhaps you also want to understand better how you can recover capital and grow overall operating margin. Perhaps there's a host of other metrics you're looking to capture as well. Perhaps it's length of stay and readmission stats that are important to you that you need to understand as a patient experience from admission to discharge or potentially readmission. So today what you're going to see is a system that was developed in a hospital setting and one that will meet the needs of hospitals of today and the demands that are being pressed upon you in terms of profitability and your overall value proposition to your community. So we'll go ahead and we'll get started now. FTI Catalyst has been in business for 17 years. FTI focuses on data management, and of course, in business intelligence and data warehousing as our core areas of expertise. Our industry experience is pretty broad, and we have worked with some pretty heavy hitters in financial services, of course, healthcare, higher education, and the life sciences. And we also provide a human capital component so that we can assist you in your own initiatives where you need expertise in systems architecture, data warehousing, and any other processes internally related to your IT initiatives where you need expertise. We look at this solution as an end-to-end solution that identifies source systems and culminates in dashboard presentation via our data model. In between, there's a lot that happens with integrating your systems, mapping and understanding the source systems of record that you wish to communicate with. We look through and parse through the many different sources you have to understand historical data, your change data, current data, and bring that into a data warehouse where our data model sits, where we can begin to assist you in daily awareness of performance, productivity, and profitability. So these are our expertise areas. We are a gold certified partner of Oracle, and we also work with Tableau as well. We're implementation specialists, system architecture specialists. We can help you with design and builds that you're interested in achieving that maybe aren't related directly to our product. So if you have something happening in your organization where you feel you need assistance, consulting, expertise in healthcare as well as technology, that's where FTI can assist you. The idea here is to provide a host of services, of course, that help you reach your goals. And this sort of DEVO model, if you will, this design, implement, visualize, and optimize is the mantra we live by every day. And, of course, you have competing priorities all day long. But at the end of the day, we want to help you achieve your initiatives, whether it's capital recovery, whether it's case margin growth, whether it's physician preference item issues, or the host of other issues that may be related to payers, improving quality and value to your payers and your community. At the end of the day, data ultimately is money. It is your way to prove what you've done and what type of value you're providing. As you know, quality and value isn't in the hall closet down the hall. It's not easy to prove, and solvency will be a key component going forward as you handle the influx of new patients. And to that extent, our experience, our vast experience, could be of use to you. Our healthcare clients, our financial clients, our media clients, they all are a reflection of our expertise in technology and bringing ideas to fruition in your organization. So I'd like to introduce at this point Dan Gerena. This is his handsome mug here, and Dan is our product manager. Dan was involved in developing this product on the job every day, and so I'd like to turn it over to him so you can hear from someone who experienced the challenges you experience every day and solves them with FTI Catalyst. Thanks, and here's Dan.
Thanks, Brendan. So, as Brendan mentioned, my name is Dan Gerena. I'm here. So at any point in time you have any questions, let me know. But essentially what I want to do is walk you through what our product is and show you a bit in terms of content and functionality. The intent of today is really to give you an idea as to what the solution looks like and really to give you a live demo. So after I'm done with a couple of slides that explain what it is exactly, I'll jump right into a live demo. A little bit about myself. Before I joined FTI about a little over a year ago, I was the Director of Business Intelligence and Analytics at a 5-hospital healthcare system in Buffalo, New York. And so this was my job all day, every day, essentially, was to, before joining FTI, I was responsible for the strategy and the implementation of a balanced scorecard approach in a large healthcare organization. So we effectively built a team here at FTI to replicate and essentially productize and leverage all of that expertise. That's really what you're going to see today is a lot of that. And so let's explain first off what Catalyst represents. So every healthcare organization has multiple source systems. At where I used to work, for instance, we had Lawson as our ERP system. We had Cerner as our EMR system. We had Kronos as our time and attendance system, etc. And so, you know, everyone has disparate source systems, effectively, that house very important information. What we've done is design a data model that captures all of the relevant attributes. And so we've pre-designed a data model, so you don't have to start from scratch. I spent a good 7-8 years in my prior job just designing the data model itself. You know, what fields do we need to capture, and doing that iterative process where you refine it over time, learn from your mistakes, etc. So we have a pre-built, predefined data model. On top of that data model sits a series of pre-built dashboards. So when the data model is pre-built, you can pre-build the dashboards that sit on top of it, and that's what I'm going to show you today is that layer of dashboards, which is how your users will consume the information. So our solution is agnostic of source, whether you have Epic, whether you have Cerner, whether you have Lawson, whatever source systems you may have. What we do is effectively work with you upon implementation to map those data sources to our data model. Once your data is hitting our data model, the rest is done. Whereas in a normal BI implementation, you have to go from A to Z, start to finish, and with a lot of false starts and reevaluating things along the way. So really, we're eliminating a lot of the manual effort, a lot of the hard work, effectively, of building a data model and an end-to-end solution by leveraging our expertise in this realm. So that's effectively what Catalyst represents and what you'll see. You'll see the dashboards that are built in order to present that information to your users. But the value add is not only that dashboard, it's effectively that data model that was refined and honed over a decade. That's essentially what the Catalyst data model represents. So our data model is built for specifically, even though it can be applied, for instance, at an individual community hospital. My experience has been a large healthcare organization with multiple hospitals. So where I used to work, for instance, we had a pediatric hospital and then 4 adult acute hospitals. And then we had everything that comes with a 5-hospital healthcare system, such as off-site clinics, emergency rooms, labs, etc., VNA, everything that you would expect from a complicated delivery system. So our data model is such that it's designed to allow you to see the results either comprehensively across sites as in aggregate, or you can compare the results to each other across facilities. And so for various dashboards, that becomes useful. For instance, if I'm going to look at a metric that may have some relationship to the patient population being serviced there, or the physicians who work there, or the nursing units within that individual hospital, I can very easily compare the results of hospital A to hospital B for similar types of patients. For instance, if I use APR-DRG, for instance, as sort of a way to cohort my patient population. So our data model is designed, EJ, to handle multiple facilities seamlessly. We've already built that logic into it. So what I'm about to show you, it really comes in 2 flavors. And when I say flavors, I mean the actual end layer in which your users consume the information. We've built our solution in Oracle Business Intelligence Enterprise Edition and Tableau software. In terms of which one would be right for your organization, really depends on a number of factors which we can address at a later date. But I just wanted you to be aware that we've taken a look at the best-in-breed BI tool sets out there, and we've chosen to build our end product in both Tableau and Oracle solution. And there are a lot of functionality in both, and I'll show you, for instance, today I'll jump into the Tableau version of our tool, but just be aware that you have 2 different flavors, as we call them, in terms of the solution, and which one would be right for you depends on a number of factors in terms of your audience and how large it is, and whether or not you need to do more ad hoc analytics, etc. So any questions for me at this point? So what we've got on screen here is our balanced scorecard approach view of the data. This is effectively what your users see when they jump into the Catalyst dashboard. So you can see here we have content segmented. So I have financial metrics, operational metrics, quality, staffing, a module around emergency department, a module around productivity, and a module around core measures. So what we're really trying to do is not only implement this in a seamless manner in which you have a balanced scorecard approach, but also a lot of what is healthcare being as complicated as it is, you can't really look at many metrics on their own. So if you're looking at profitability, for instance, profitability is a function of your payer mix, it's a function of your case mix, it's a function of length of stay in terms of cost, it's a function of utilization in terms of what resources are being utilized by your physicians. So there are very few metrics that aren't driven by other metrics. And so it's important to have, when you're going to implement a BI solution, you could, as I did in a prior life, go incrementally and go from subject area to subject area to subject area over the course of years. But the real leveraging of the data comes in when you have an integrated solution implemented all at once. That means you get a critical mass of users using the solution, and you get rid of all those, access databases and desktop spreadsheets that people are maintaining, and you really have everyone focused on speaking the same language from a report solution perspective. So what you're seeing on screen is essentially the content that we have, and what I'll jump into in a second. So this is a similar screen to what you saw on my last slide, but I'm actually in the tool here, and we've got the content as I mentioned. And so the content map serves, as a navigation methodology for your users. So number one, they know how to access all of this information, right? We've got a ton of information, a ton of dashboards, about 30 plus dashboards, and obviously I'll just go through one or two today and then see if you have any questions on anything specific. But it's designed such that the dashboard also serves as a launching point into the content. So for instance, I'm looking at the patient profitability dashboard. And at the very top of the screen, you see a number of drop-down filters, right? The intent is to have not 20 or 30 different reports that show profitability, right? There are a lot of folks, when they implement BI solutions, they have a profitability report by hospital, a profitability report by financial class, a profitability report by product line, by physician, et cetera. What we're trying to do here is have one dashboard which everyone can use to answer questions related to patient profitability. So to do that, there are a number of options we have. First off, you see a number of drop-downs, right? So this is an example of our product line drop-down, right? I'm looking at orthopedic surgical patients, but if I was in charge of cardiology, obviously I'd look at cardiology. If I was a hospital president, I would look at all product lines across my particular hospital, for instance. And obviously users can look at different date ranges, et cetera. So that's a little bit about in terms of the content and functionality. Let's take a look at some of this data in its context. So every data point here represents a different patient. Okay, so you can see as I mouse over the patient or I hover over it, I can see who the patient was, what insurance they had, their length of stay, who the physician was, et cetera, right? So a lot of information is exposed to the users immediately. If it's in red, that means I lost money on the case. If it's in green, it means I made money on the case. So on my x-axis here, I have my profitability, right? Everything to the left of this line here, that zero line, means I lost money on that case. And my y-axis here, that's total charges. So we have a scatter plot, effectively, where every patient is the intersection of the total charges relative to the profitability I made on that particular patient. So that's what the color denotes. The shape denotes something else. So in this particular case, I have my field selector set to financial class. So the shape denotes the financial class. Here's the legend here, right? So I can very easily, for example, I can select Medicaid, right? I can highlight on my legend Medicaid, and those diamonds pop to the front. Everything else moves to the back. So I can see I had one unprofitable orthopedic surgical patient for my Medicare financial patients, for instance. So I'm very rapidly, it's not just the top layer of, hey, here's the data. We've built this such that it's interactive and intuitive. You can easily start to ask a number of questions about that data. So as I selected Medicaid, you can see it's highlighted in this table here. I have 30 patients, and I can see only one of them where I lost money. I can see who that patient was, who the physician was, et cetera. And I see for those 30 patients what the average length of stay was, the direct costs, the average charges, and then the average margin per case. So for those 30 patients, I made on average $2,800 per case for those orthopedic surgical patients. So here's an example of interacting with the data, right? I can very quickly see who these patients are, and further, visually, it tells me a story where I can see my Medicare patients under orthopedic surgical. I have a lot more patients where I lost money. The beauty of this tool is it's highly interactive. So I don't have to look at it by financial class, for instance. The financial class doesn't have to be what denotes the shape. I could, for instance, select APR DRG. And so now I can, again, remember I'm looking at orthopedic surgical patients. I can look at all my DRG 308 patients, right, and make that pop, right, visually, and everything reacts to that. So we built it such that it's not just a top layer of 50,000-foot view, but we built it such a manner where you can then start to ask questions and poke at the data without having to go back to the BI department and ask for a separate report that way, et cetera, right? So a lot of functionality. I could, for instance, toggle it to surgeon, right? So this is essentially the spirit of every dashboard we have here. It's not just a matter of saying, hey, here's the data, but we built it such that your users will interact with the data directly and start gaining insights from the information. So that's essentially the spirit of the tool and the dashboard itself. Another interesting thing in terms of functionality is I could lasso these two particular patients, for instance. I could, draw a box around those two patients. And if I scroll down, I can see those individual encounters. So I'm very quickly going from the 50,000-foot view down to street level, right? Now I have those two particular patients, and I can see what their length of stay was, what their costs were, who their physicians were, et cetera. So highly interactive information, and the intent is really for your users to be able to delve in there directly and start asking questions of it directly without having to, follow up with finance or BI or et cetera. So that's just one example of a dashboard around patient profitability. Any questions for me in terms of content or functionality? So let's continue along here, and let's just talk about one or two other dashboards, and I'll open it up in terms of if there's anything specific you want to see. So we talked about patient profitability. This is the same type of information, but it's at the physician, from the angle of evaluating the physicians. So again, looking at orthopedic surgical patients, I have a little slider here. Let's say I only want to see, physicians that have at least 50 encounters, for instance, right? So I can control that slider and so I don't see all the onesie twosies, et cetera, or I can expand it all the way and see all of the individual physicians, even the ones that have only one or two cases in whatever the specified time frame is. But each bubble represents a physician here, and the size of the bubble represents their patient volume. So I can quickly, again, I have the same axes, right? I have total charges and I have margin per case. So the more rightward I go, the more profitable that particular physician is. So Julian Ingram had 171 encounters. Length of stay was 2.2. So again, I'm looking at orthopedic surgical cases here. This is effectively a peer group of physicians, and I can evaluate them relative to each other in terms of their profitability and also the size of the circle representing the patient volume. Down here in the lower left-hand corner, I have the same information but by physician group. So if I, for instance, click on physician group 28, I can see those three physicians in that group pop to the front of the data above it. So I can understand the relationship between physicians and physician groups and, that sort of relationship in terms of profitability. So if I understand which physicians and which physician groups tend to make me more money than others, obviously if they're a surgeon, I may take that into account when I schedule OR time, right? Those sorts of decisions. So as you click on these bubbles, you'll see, for instance, I click on this bubble. Over on the right-hand side, I can see over time, instead of a window of time, but over time, trended over time, I can see the volume of physician group number 7, how that changes over time from January through December, for instance, and their profitability per case. So I can see their profitability per case has been increasing, and overall, their volume seems to be very sporadic. It looks like maybe they took some time off in the summer months or so. But for the most part, the volume seems pretty steady, and the profitability per case, though, is increasing over time. So a lot of insights can be garnered from this type of presentation of the data. So all the dashboards you're seeing, we're using visual best practices. How do we convey a story? It's not a bunch of tables or a bunch of bar charts that you would normally see. We spend a lot of time understanding what the story is we're trying to convey and what are those insights, and presenting them using the best type of visualization. So the model effectively is fed from your source systems. So the majority of our clients, they have a cost accounting system in place. So for instance, where I used to work, we used EPSI as our cost accounting system. We had a cost accounting module, and we would do the costing in terms of direct and indirect costs, and that would be an input into our data model, which these particular dashboards sit right on top of that data model effectively. So all of the data comes from your systems essentially. So in theory, you can do predictive analytics around a number of metrics, right? You can, quality metrics, financial metrics, etc. So the first when you're talking in terms of BI maturity, the first thing you need to do is get disparate data together in one place, and that's what our data model represents in order to have a comprehensive balanced scorecard approach. By attaining that level of maturity, it gives you all of your retrospective historical data. So you can't do prospective analysis until you have all your historical data, obviously. So our data model essentially represents when we would initially implement it, we would naturally backload a few years worth of data into the data model. And so it essentially serves as the starting point for whatever direction you want to go in whatever metric. So all of these dashboards, first off, are customizable. If you want to take it in a different direction, or you want to get more advanced or sophisticated, or let your users specify inputs and model things, that's all in the realm of the tool set itself, and you can take it in any direction. So just because we implement on implementation day this set of dashboards, the beauty of this is that if you want to go in a different direction, or you want to build a dashboard, a physician scorecard, for instance, that plucks metrics from multiple content areas on this dashboard, etc., you're free to do that. Same is true with the data model. Just because we bring in a data model that captures a lot of the relevant data, if you decide, I have a bariatric center of excellence and I want to capture BMI, and that's not in our data model at present, you can add new fields, you can add new tables to the data model itself. So the beauty of this is it's getting you to the basic core of where you need to be, in terms of basic blocking and tackling, and obviously I'm minimizing what we have here. It's awesome, but let's just call it the basic blocking and tackling. But from that point on, you can take it in any direction you want in terms of predictive analytics, in terms of other content areas. So there's nothing pre-built in terms of predictive, but obviously we have healthcare expertise and we have the toolset expertise, and our intent is, as we deploy, to transfer that knowledge to you. But if you want us also to assist in that manner in building something new in terms of content, we'd be more than happy to do so, EJ. So Eve, let's just talk in terms of, say, readmissions, right? So obviously readmissions historically have been a quality metric, so it's under quality. It now has financial implications, right? So you're now going to be dinged financially if you have readmissions, as well as having patients, not be dissatisfied because they have to come back, etc. So here's an example of our readmission dashboard. This is, I'm showing here in the top here, for whatever, again, I'm looking at orthopedic surgical patients only in this case, right? So I see a trend over time being broken out here by the, mute you again, sorry. I see, let's talk about 30-day readmissions, Eve, for instance. I can see the number of patients who come back on the same day they were originally discharged, and so I can see that 30-day window here. So the majority of patients actually tend to come on day 6 in this case, for whatever date range I ran for this particular product line. And obviously that may be different for cardiac patients, right? So I can see that patients who are coming back immediately, that's going to be a different set of issues and root causes than those that come back, 20, 30 days later, right? So this is an example of binning a sort of a histogram of when patients actually tend to come back relative to the day they were discharged. So it's a pretty unique view of the data. Here is an example of, in the lower left-hand corner, of readmission rate by surgeon. So again, I have that flexible field selector. I can pick financial class, for instance, and I can see for all of my respective financial classes or physicians, etc., what the respective readmission rate is. So I can see for this particular financial class, I have a high readmission rate relative to other financial classes. And then this is sort of parts of a whole. So I can see all my Blue Cross patients, and that 4.4% of them were readmitted within 30 days when I'm looking at orthopedic surgical patients, for instance. And then this is more so, it's similar, but it's the raw data. So even though I have a very high readmission rate for future insurance, I can see that my volume is much lower relative to, say, Blue Cross, right, in terms of total patients. So the little red bar are the readmitted patients, and the gray bar are the total patients. So I can see sort of the parts of a whole there. So that's an example of just understanding your readmissions and fundamentally what's driving them and what you can do to sort of prevent that. So our dashboards are interactive, and the intent of them is not only to understand, to report yesterday's news in terms of where you had readmissions, but the way we used to use this where I worked was to identify the root causes, put changes in terms of processes and protocols and procedures in place, and then use these dashboards to measure over time whether or not we're improving. So it sort of solves both itches, essentially. So that's an example of a quality dashboard. We also have quality dashboard around mortality rate, right? So understanding which patients are expiring. Again, I'm looking at orthopedic surgical patients, and I can see trended over time, in terms of the mortalities. So the top, I have my number of encounters, and the bottom I have the number of expirations, and then the label represents the percent. So I lost one person in January out of 326 patients, for instance. So I can see trended over time relative to total volume. And I can further look at those expirations in this window of time. Looks like I had 11 expirations. So here are those patient expirations broken out, and I can see the color represents the financial class because I have it set to financial class. And I have it by severity of illness. So I had 3 patients who passed on in orthopedic surgery, and they had a severity of illness of 2. So obviously I may want to understand that better and drill down and say, who were those patients, right? So I can, from any of these dashboard charts, your users can drill down and understand who those patients were, what the circumstances were, what the DRG was, what the length of stay was, any primary, secondary diagnoses, et cetera, right? That sort of thing. And then down below I have a heat map that shows me, makes it pop out when I have a specific issue in terms of expiration date. So obviously for commercial insurance in the month of October, I had a very high mortality rate, and obviously I can drill down and see who those patients were. So yeah, so the reason is really going to be a variable dependent on a couple of things. Number one, is it an orthopedic patient versus a cardiac patient, right, versus a behavioral health patient, right? So a behavioral health patient is not going to be coming back, for instance, for an infection, right? But they may come back with an issue for their meds, right, that sort of thing. So the way we built this is such that you have the ability, to look at this from myriad types of product lines, and you can even combine them if you wanted to, right, and to understand who are those patients that are coming back. So as I mentioned, we have this field selector here. I can look at it by surgeon, for instance, right? So I can see my behavioral health readmits. Well, in this case, they won't have any very minimal surgeries. That's why this is so long. But let me look at the, by the attending, for instance, instead, because it's not a surgical product line. But I can look at it by physician. I can look at it by nursing unit. So there are a number of potential drivers, and a lot of it depends on the type of patient, right? So if it's a surgical patient, if you're documenting why they're coming back when they get readmitted, then yes, that would be exposed to you in terms of the reason. But oftentimes you're not, right? Oftentimes you see that they came back 7 days later. Right, you see the same medical record number coming through the door. So you, to some extent, have to have an analytical tool like this to understand and try to determine why. Is it that the nurses are not giving proper discharge instructions, right? Is it that the patients are being dispositioned to home without services for certain types of patients. So maybe we need to discharge them with services, right? Is it a physician-related issue, right? So a lot of it is very variable, but it's variable based on the type of patient we're talking about. So this is really the way we built it is such that there's never going to be an algorithm you can run this stuff through and say, okay, you need to fix this, because it's so dependent on whether it's behavioral health versus someone who just gave birth to a child or a newborn or et cetera. So we've designed it such that it sort of makes it easier to identify the root causes, but there may be a myriad of root causes, and then you put processes and procedures in place to sort of address them and then monitor that over time. Now, let's say, for instance, you identified that the reason is X, right? Then you can sort of be predictive about it and say, well, how many patients? Let's say that a large reason why newborns are readmitted, I'm making this up, was that their parents were smokers. Okay, so I have that information in my data model in terms of when the mother was discharged, whether she was a smoker or not, and if I find that that's highly correlated, right, with a readmit of a newborn, right, under a certain weight, for instance, right, then I can say, okay, as these newborns get discharged, or as we admit these mothers into maternity, we need to give them instructions around, not smoking, near the baby or whatever the case may be. So then you can sort of be more predictive and proactive and say how many mothers are coming in that are smokers, right? And and did their baby is their baby under a certain threshold in terms of weight by grams or whatever the case may be. But you sort of have to do the work of making that correlation because people are not, as you know, people are not widgets and they're not running through an assembly line. They're all different and they all come with their own predispositions and ages and that sort of thing. So one final dashboard I'll show you, and then I'll turn it back to Brendan. As I mentioned, we have a dashboard around emergency departments. So a lot of hospitals make money off of inpatient discharges, and a lot of inpatient discharges are driven by emergency department visits. And so we have a module just focused around ED patients. So for instance, I can understand where patients are traveling to get to my particular facility. So here's a map by zip code, for instance, a heat map by zip code. I can see information around why patients are being admitted. So for the cohort of patients that are being admitted, why? For those patients who are expiring, what are the primary diagnoses for those patients? So it's more so quality-related issues in terms of ED patients. I can look at a heat map of when patients are arriving by day of week and hour of day. So I'm going to guess that for your particular hospitals, 11 a.m. on Mondays are the busiest time in your emergency department in terms of ED arrivals. And so before we had this information, we assumed, maybe it's the weekend or whatever. But once you understand when you have peak times, you can understand the whys behind it and staff appropriately or work with insurers to if it's business hours and they have primary care physician, they should be seeing their physician first before showing up at the ED, that sort of thing. So understanding, when patients are arriving, which patients are being admitted, where they're coming from, even understanding throughput. So from arrival to triage, start to complete, triage complete to when the bed's assigned, et cetera. All the handoffs in the process are really important to ensuring that your ED is operating effectively and efficiently so you can bring patients in appropriately and have fewer absconce or patients who leave without being seen, that sort of thing. So very comprehensive dashboard just focused on emergency department, which tends to be a large driver of inpatient volume, which tends to be a large driver of profitability. So again, there's over 30 dashboards. So when we do implementations, and even in my past life when I was responsible for doing this at my hospital, we oftentimes had multiple source systems. At one point we had 3 different billing systems, right? And certain time stamps get captured in different ways. Some of them are a scan of a barcode, some are manually input. But effectively what we do when we implement this is we sit down with you and say, okay, here's our data model. We go field by field and say, what do you consider the source system of record for instance, emit date and time, and what system should we pull it from, and what is the cadence of that? Does it get updated over time? Should we pull that daily? Does it ever change? You know, so we have all those conversations, and within those conversations, that's when we'd say, for instance, okay, let's say one system you capture gender as an M or an F, and another system you captured it as a 1 or a 0, right? I don't know. So when you move the data from wherever it lives to the data model, you have the ability to normalize it, right? So you have the ability to build calculations and that said, okay, if it's from this source system, then the nursing unit is this, then make the value this, otherwise do this, otherwise do this, right? So you have a lot of flexibility that you don't have when you report off of the data in where it lives in the source system. So the data model not only brings together your disparate data from across systems, so you can interrelate profitability with readmissions, with whatever length of stay, et cetera, but even for a particular subject area, you're normalizing it such that you're making all of the definitions mean the same thing. So profit, when we compute profitability, it's going to be payments minus direct costs. And so anything that's an indirect cost goes in the indirect bucket, these allocations go in this bucket, et cetera. So you have that opportunity at that point to sort of bring some sense and normalcy to that fragmentation that you have in the source system. So that's sort of what we do when we do the implementation with you, and we map out where your source systems are and map it to the data model. But once you do that step, these dashboards that you see here, they're all pre-built. Once we replace our data with your data, you're good to go. It's a turnkey solution, essentially. So Brendan, I'll turn it back to you.
Okay, excellent. Thank you so much, Dan, and thank you everybody for joining the webinar. One of the things that I just want to underscore as we part today is that what we've tried to offer you, as I alluded to in sort of my preamble, if you will, is an opportunity to intervene and make a difference in real time, which is when you have latent reporting and you're looking at length of stay or readmissions and your report is 30 days old, well, the game's over. The points have been scored. The box score is sort of irrelevant to you at that point. So what we want to offer you is an ability to jump in and capture, lengths of stay that look like they're getting long and readmissions that look like they're growing from a particular provider or service or financial class, for example, give you the opportunity to intervene. And we're parting today with the final screen that you're looking at now is actually a model from our productivity model. And whether you're struggling with supplies or labor in terms of your costs, we can really help you affect things in real time when it comes to labor. So we didn't really scratch the surface on that, but like Dan had mentioned earlier, if you're looking for an opportunity to learn more and sit one-on-one and go through this system with me one-on-one, I'd be obviously more than happy to work with you, and I have my contact information here for you. So again, I'm Brendan McCauley with FTI Catalyst. And on behalf of Dan Gerena, thank you all very much for attending today. And please don't hesitate to be in contact with me if you wish to discuss Catalyst further.